think we can start. Welcome to everybody joining this VTE and Movement session being held at Let's Talk Clots, which is in support and celebration of World Thrombosis Day. This is a very different topic than we've had previously, but when we reached out to our speakers to be part of this session, we knew we were asking a great deal. For Thrombosis UK, the discussion around VTE and recovery or returning to any exercise and movement is a popular and frequently asked question, both from patients, but also from healthcare professionals. And we answer many queries. We've sent out tens of thousands of leaflets that we've had medically approved on this. And actually the film on first steps to recovery of restoring activity after diagnosis of a blood clot has received almost 300,000 views. So it's a really important popular topic, but one with very little information or research around. So today we feel really, really privileged to have these two speakers. One is Alex, who's going to provide us with a patient perspective of what it's like to try to rebuild and return to an exercise and hobby routine that he enjoyed prior to his diagnosis. And the other, more of a medical review from Professor Stephen Black, a vascular surgeon who many of you will already know. So I'm going to pass over to Alex now to begin his story and to share his experience. Thank you, Alex.
Thank you, Jo. It's an absolute pleasure to be with you all today and to have the opportunity to be able to speak about what it's like to rebuild after a VTE and what that means in terms of both physical and mental challenges that were faced. Again, it's a real pleasure to be involved with this very important event, and I hope that this is informative and also helpful for many of your patients. So what was the context? In early 2020, I was diagnosed with pulmonary emboli. At first, it was, well, why did this happen? What was going on? Why me? All of the classic questions that are asked. But in a nutshell, there was a lot of flying over an 8-week period as part of my job to a place in the picture, long-haul flights that were involved. And I appreciate that there's a lot of people who'll either be watching this or have dialed in live. That place in question, beautiful part of the world, Pakistan, Islamabad, which was stunning. But at the time, pretty difficult to get to, which involved a lot of overnight flights, a lot of early mornings, a lot of late nights, a lot of turnarounds as well. And this was underpinned by something that I certainly didn't know about, and neither did members of my immediate family, my brother, my parents, and so on. I was factor V Leiden positive, which came about post-diagnosis. In terms of how this was identified, I would say in a nutshell that it's the most weird sort of pain I'd ever experienced. I had no swelling in my legs or groin, but I woke up one morning and I was due to get on a flight back to the UK where I'm based. I had a feeling that I'd been kicked in the ribs by a horse 3 days before I ended up in hospital. Many years ago, I used to play rugby, and I once did a rib cartilage. And it was very similar to that, but more intense. And given that I hadn't played rugby for about 10 years, I did wonder what was going on. I wasn't able to get comfortable at all on the flight back, or even on a chair the following day, and I was constantly yawning. I thought I was tired, I thought I was jet lagged, but in hindsight, that was the breathlessness due to the pulmonary emboli. On the night that the yawning, the breathlessness was happening, I couldn't sleep in the bed, I was too uncomfortable. So I ended up sleeping on the floor, which itself should have been a warning sign. This continued for the next day and the next night. Before I woke up, the morning I was due to get back onto a flight to Pakistan, I had a strangely swollen face and incredible pain when I was moving and or breathing. So instead of going to Heathrow Airport, I wisely took the decision to go to the nearest emergency department. I was initially told that it could be kidney stones until a CT was undertaken. And the news was given that I had pulmonary emboli. that was obviously a shock, having been very active and physically fit my entire life, and unaware that this sort of thing could happen to me. You know, before anything like this happens, I must admit, I felt like I was never really going to get old. I felt like I was going to be physically fit for my whole life. The physical activity that I do really helps mentally as well. So this came down like a ton of bricks. I remember the initial diagnosis thinking, am I ever going to be in a position where I'll be moving without pain, where I'll be healthy, where I will be able to get back to my previous levels of activity, which will help both mentally and physically. So the following day, I was back into the hospital to talk about what that first step to recovery looked like. I was very sore as a result of what had gone on, still a little breathless, although the blood thinners that I'd been placed on the day before had started to already take effect and kick in a little bit. So I had a really good conversation with a hematologist at the hospital. I was lucky enough also to be put in touch with a private hematologist who I also spoke to through a contact of mine. And the consensus was, let's start to build activity up nice and slowly. There'll be obviously some damage to the lungs where these clots were. We need to break them down, get you moving, get everything going nice and gently again. Obviously, I'm not a clinician. Those are my overriding memories of the advice that I was given. And as I'm not a clinician, that really sunk in terms of what does it mean to be a layperson who's got this sort of thing, what really resonates, and the message that was given to me about how I start to get back on the road to activity. So at first, day one, week one, get out, get active, get walking. 20 minutes twice a day. Just make sure that you're not pushing it too much so that the pain is not there as you're doing this sort of thing. Make sure that you're not really pushing yourself too hard, that your heart rate is going through the roof or you are too breathless. But have a walk, take in the sights and the sounds and the smells around you, because again, I was thinking the whole time, if I'd have got on that plane, I might not be outside walking where I am now. So for the first month, it was a real case of, right, getting into a routine. The alarm goes off in the morning, have a shower, have a coffee, bite to eat, out for a walk, take it all in, enjoy it. And then do the same again at night as well. That really allowed me to switch off. And I also think switch off from the diagnosis that I just had. But over the course of that first month, I did start to feel myself not being as breathless, being more confident in my body, being more confident in being able to walk more briskly, longer distances. So started to build up the 20 minutes into 40 minutes. And at the end of that first month, I was probably doing, at the weekends anyway, a good sort of 60-minute walk where I was comfortable with what was going on. After that first month, I had another conversation around how I was feeling, what that looked like, what that felt like. So it was then a case of getting into a little bit of gentle cycling. I had previously enjoyed my cycling due to a number of knee injuries. I'd done that a lot for rehabilitation. The hardest thing with that was not to push it. Although I was feeling pretty good, I was very conscious around what that could mean for the recovery period. And when I was being re-scanned, which was going to be a 4 to 6 month period down the line from that initial diagnosis. So I kept the walking up, but I also introduced some gentle cycling. And by that, about an hour, 2 to 3 times a week. Again, not head down, flying through traffic, but gentle lanes, taking everything around me, just making sure that I was exercising at a level that didn't feel uncomfortable, but felt challenging given the circumstances. So that looked like month 1 to 3. It was probably around the start of month 3, I started to be able to exercise with fewer concerns and pain, and build that up a little bit more in terms of the length of the rides I was going on, the intensity of the rides I was going on, and also introduce a little bit of gentle jogging. I was rehabbing at the time as well. due to an operation, probably 3 months before I'd had the diagnosis of PE. So all of that fit together quite nicely. The challenge was from month 3 to 6, when I did start feeling better in myself and better mentally and more confident. It was, how do I step it up, and what does that look like? And are there any guidelines for how you should be stepping it up in terms of how you're feeling, what your heart rate's going to, how you're listening to your body? It felt like I was flying a little bit blind in terms of all those different parameters. And I appreciate that's going to be different for different people. We're all built differently. We've all got different levels of activity. So as a result of this, I was really building up my physical fitness between months 3 and 6, which was great. My body was responding well, but I forgot one key thing, and that was, it was the mental side of it. And I appreciate this is all around movement and getting back into exercise, but so much of this for me was also mental. I was very anxious as a result of not having experienced anything like this before, being completely tuned into my body and the pain and then the recovery and what that felt and looked like. And then what that meant mentally as well. Am I pushing too hard? Have the clots completely gone? Are they still there? What happens if I push too hard? What happens if I don't push hard enough? All of those types of things which were playing on my mind. There was the residual thoughts around, will I ever be normal again? Whatever normal means, to be able to exercise to an intensity that I need to do to feel happy, to feel good in myself mentally, to feel physically fit. Was this it? Had I got to the point where I wouldn't be able to exercise at a level that I'd ever been able to previously? I also had a smartwatch at the time, which was a hindrance and a help. I'll happily admit that I didn't find that healthy balance. I was constantly checking my heart rate when I was resting, when I was walking, when I was cycling. And for those cyclists out there, it's not a good idea to look down constantly at your watch when you're in traffic or on roads or speeding around corners. So from a physical safety point of view, I'd highly recommend against that. But it was all around getting that balance right and not letting the heart rate determine my mood or anxiety levels, how I was feeling. In terms of what the main challenges were for rebuilding physically, on a couple of occasions when I was out on the bike, I had mild arrhythmia. In hindsight, it's probably influenced by my increased anxiety and maybe in some cases pushing it a little bit too far, too quickly. This did lead to a number of comprehensive tests about 5 months post-diagnosis, which all came back clear, and I guess provided another level of comfort as to the fact that I was recovering, my heart was healthy, my lungs were healthy, and so on. But another challenge was holding myself back as well, knowing where the boundaries were, knowing where to push, how to push, what on. Importantly, recovery time also. And I think when you haven't been diagnosed with some of what we're all here to talk about, recovery time's critical, sleep is critical. We all know that, but it kind of gets lost in the fog of that physical and mental challenge. And then finally, the last challenge I think I've already touched on was that residual pain when I was pushing myself, which lasted for about the first 3 months. It was still there. If I was really blowing quite hard, breathing in deeply, I could still feel that pain, whether it was psychosomatic or not, who knows, but there was something still there when I was pushing really hard. But in terms of how that felt after 6 months, I was re-scanned. The clots, thank goodness, had gone. My fitness was being built back up. Physically, I felt great. Mentally, though, I must say that it did take a lot of time, and we'll get onto that. But how was everything, and how is it now? Well, I'm more conscious of movement, not just fitness, but movement. Flexibility, keeping active, walking, than I've ever been in a positive, balanced way. Time is great. Reflective time is great in terms of what that felt like at the time, and then what it felt like from months 6 to 12, but in particular 12 to 18. I think that's where I started to really feel better physically and mentally as a result of this. So I think one of the key takeaways is when you're speaking to your patients, it is be patient, embrace that time, treat it like recovery as it should be. Be thankful for that opportunity to be able to move and focus on yourself when you're out rebuilding that exercise and those intensity levels. Focus on being healthy for you and the others that you love and your family. Be kind to yourself. It does take time. It takes time to rebuild to a level. It takes time to rebuild that physical activity, and follow the guidance. I think the most important conversations which still resonate with me were the ones that I had really early on about getting back to fitness, getting back to movement in those very early days. That obviously plays to what people put importance on, and I did, so that really sticks with me. But it was about getting to a point where I was using that movement to focus on the next few weeks, the next few months, and then ultimately what that would look like in 6 months when I was rescanned. I would also say be conscious, but not totally reliant on your smartwatch. Listen to your body. If I could do things differently again, which I wish I never have to, and wish upon your patients, if they've gone through this, that they never have to do it again as well. It's listen to your body. Don't follow your smartwatch. Be aware, but don't let it determine your everyday mood. I guess the main thing I did miss, though, was exactly why Joe and I have spoken, and feel really privileged to have this opportunity today to speak to you all. It was to have somebody to talk to and share experiences. So I would say that when you're speaking with your parents, with your patients, encourage sharing, communication, network building amongst them. It was something that I wasn't aware of at the time, and through Thrombosis UK, I am now. And I'd like to say thank you for the great work that they all do, because this is all doable. And however challenging and tough it might feel at the time, and however threatening it might feel, people can get back there. So I would leave you with that message. Thank you very much for that. I am really happy to take any questions that you may have. And I believe that I've stopped sharing my screen now as well. That should be back to the main page.
Yeah.
Thank you, Alex, so much. And I think the experience you share is true of so many people, regardless of where they were starting from, so what exercise they did before diagnosis. It's that confidence and that reassurance of how you return to the level that's right for you. You mentioned, at the end, the takeaway points of sharing. Were you able to find, beyond Thrombosis UK, but anyone who gave you that reassurance or further tips along the path to the recovery and return to the exercise that you wanted to do that was really helpful, or anything there that you found really helped to encourage you and reassure you?
I think Thrombosis UK were key in this. I think the online material that was available and that you'd published and made available to the public was absolutely brilliant. And I'm forever grateful for that. The conversations that I had with the haematologist at the hospital and the private haematologist that I saw as well, again, I'll never forget those two people who really helped with what that looked like and what that felt like. I guess what I did miss were networks of people who'd gone through the same thing. And Joe and I have spoken. I was lucky enough to be invited to a conversation with other people who'd experienced the same thing, so other patients very recently as well. And it was just fascinating because they were far more close to their diagnosis than I am, and a lot of people on that conversation, that call, were in a similar position to where I was 3 months and 6 months in, who were genuinely worried about their levels of activity. Would they be able to get back to them? So at the time, I think that was the main thing that I missed the most. But again, the conversations that I had with with the two medical professionals that I saw, and the work that Jo and her team have done was absolutely invaluable.
That's very kind, thank you. And I guess the other point she raised, which for the audience hears, it's about trying to have the confidence and knowledge to understand the physical recovery, the pain or breathlessness you might still experience for a period of time or an extended period of time, as well as the emotional, mental health recovery, and even the starting points. But I think the message that you gave about, most importantly, listen to yourself, be kind to yourself, is reassurance. I would find very, very reassuring, because it gives you the opportunity that you can do this, but it will be in stages. So thank you very much for your talk. If there are any questions that come through, please do put them in the chat or the Q&A, and either later or Alex.
There's one question up there, Jo.
Oh, right. Sorry.
Not an anonymous question. Alex, this is really to you. You mentioned you had a surgery a few months before the clot. Did that have an impact on your physical activity before the clot?
It did. Yeah, I had an ACL reconstruction. So for the 3 months before the clot, 1, 2, 3, it's about 4 months before the clot, I was rehabbing my knee. I wasn't able, obviously, to go running, but I had started on a static bike in the gym, and I was doing a whole load of rehabilitation exercises in the gym. But I certainly wasn't laid up on the couch for more than the 2 weeks post operation. It was something that I did raise at the time with the medical professionals that I saw, and I said, look, is this, or could this be part of what's caused all of this? They didn't seem to think that it was, because I'd been following the rehabilitation process really closely. But yeah, it's a good question. And I would say that my level of physical activity and the intensity wasn't usually where it would be because of the rehab that I was doing.
Yeah, it's always a tricky one, that when you've had an operation around 8 weeks before, and then there's long haul flights and other factors in what the final trigger for blood clot is. And I think I've always experienced it. Most patients are desperate to know what the one thing was that caused it, so they don't have to do it again. And we hardly ever can get down to that, which is a frustration.
Yeah, I think on that, yeah, I'm always wanting to know why. You know, what's the root cause of this? And part of it is letting that go as well. It could have been the flying, it could have been the clots, it could have been factor V Leiden. It's probably all a bit of everything, but who knows? And I think you've almost got to say goodbye to that and say, right, we're here. Let's get back to building up activity. Let's get back to being healthy, and try not to dwell on that.
Another question from Louise Burgess is, have you been able to access the Let's Talk Clots app? And if you did manage to, did you find it helpful?
I have now. I didn't at the time. I was very unaware. I mean, look, as I said, I thought I was invincible. I was physically active. I'd never had anything like this in my life before. So I was blissfully unaware of all the brilliant work that people were doing. I think it's brilliant. I would highly recommend it to everyone. And if you can build that into conversations with patients who are very, very recently removed from this sort of thing, please do.
Brilliant. Thank you. Thanks, Stephen. I missed those questions. Thank you. Thank you, Alex. If I move across to Stephen now, who has very kindly joined us. As many of you will know, Professor Stephen Black is a clinical lead for vascular surgery and co-lead for cardiovascular R&D, and is based at St Thomas's, Guy's and St Thomas's Hospital. And he's here to discuss today both the medical side and the guidance that we can reassure and give to patients confidently who have experienced VTE and want to become more active or just return to their general activity levels post clot diagnosis. So over to you, Stephen. Thank you.
Yeah, thank you very much, Jo, and thank you, Alex, for sharing that. It's always much more powerful when we hear the stories of people who've gone through this journey and what they've experienced. And I think I'd also take this opportunity to thank Thrombosis UK for the great work they do. I try and get as many patients as I can to join this, because I think what I find often is when people present to us with a blood clot, they feel that they are the only person in the room with a blood clot. And quite frequently we get asked the question about why we have, who else gets this? Am I the only one? And it's only when you have groups like this that people realize they're not fighting this by themselves and can find support. So thank you to everybody who works on Thrombosis UK to do that on behalf of all those of you who suffered from clot. So I'm just going to talk a little bit about the more medical side of this and the kind of advice we can give people and what the evidence is for exercise and other conservative measures in the recovery from venous thromboembolism. And basically the kind of best analogy for me is when you get a deep vein thrombosis that blocks the veins coming back to your heart. It's a bit like contemplating the M25 being 4 lanes and suddenly find it either reduced to nothing or reduced down to 1 or 2 lanes. And the problem with that is, of course, when it's midnight and you're doing nothing, the motorway is fine. But as soon as you hit rush hour traffic, the reduction is going to start building up a backlog of traffic, and that backlog of traffic is the pressure that builds up in legs when you try and exercise. But also there's a more complex bit, is that the blood then doesn't get back to your heart. And if you think of the M25 as a circuit, if you're traveling around it and you build a blockage in one area, the road beyond the blockage is empty, and that's the same as blood getting beyond the blockage, getting back to your heart. And why we find a number of patients get short of breath is not because of PE alone. It's also because they're not getting the blood that's pumping out of the heart coming back to the heart in the same rate. And we call that venous return. So the aim of any exercise treatment or the therapies that we provide, one is to try and open the M25 back up and get all 4 lanes, and that's not always possible. And if you kind of think of blood clot as it resolves, it scars the veins up. So you may only ever get back to 2 or 3 lanes, and then the hope is that the B roads that bypass that blockage compensate enough to keep symptoms at bay. But obviously we know that that's not the case in all patients, hence why some people go on to get post-thrombotic syndrome and have further problems. So when you look at the literature for non-operative management of post-thrombotic syndrome, in other words, what can be done to treat people with post-thrombotic syndrome or even deal with it, you find that there are not actually that many papers, which is typical of DVT. When we compare that to coronary disease or we compare it to any of the other major disease states, there's very little done in the area of DVT. So we found in our search, and there's a way that you do these searches to get papers out, but we ended up with 33 papers that we could analyze for treatment options, and 30 of those were looking at prevention, which is where the main focus is, and that was either using compression therapy for prevention or pharmacotherapy to prevent VTE, and very few focused on treatment. We only found 3 papers that actually gave us any information on proper research on treatment of VTE. 1 paper on exercise, 1 paper on electrical stimulation, and 1 paper on treating lymphedema, which is a complication, which is the leg swelling, but it didn't focus on the actual treatment. So if you look at those prevention papers, this was really looking predominantly at the effect of DOACs and vitamin K antagonists, on which were more likely to prevent DVT, with some trend towards favoring DOACs, and looking at the role of stockings in preventing VTE, which is very controversial, with some papers showing an advantage and others not. But on the whole, you see this black graph sits just to the left of the one, which means that there is probably benefit from stockings, right? But we know, and I know from my experience with patients in multiple groups, is that everybody hates stockings and nobody really wants them. And a lot of the time, that's the only bit of information that anybody gets, is wear stockings. And we'll cover that in a little bit more detail shortly. So there's a lot of evidence for prevention, but there's very little evidence that look at treatment options and look at what we can actually do to improve the lot of patients. And I think this is important because when you look at a lot of the clinical trials that try and evaluate interventions in DVT, and my particular interest is clot-busting drugs and thrombectomy and trying to get the clot out, patients are often randomized in studies to an intervention where you do something, or what we call best medical therapy. And if best medical therapy really is, in inverted commas, doing nothing and giving people stockings, that's very difficult to explain to anyone. And there's not a whole bunch of information on this. So the treatment options, really the one study on exercise showed that exercise therapy did improve quality of life and did improve leg strength. There was no real reduction in post-thrombotic syndrome scores, and that, so it didn't change post-thrombotic syndrome, it just did help people a bit. Electrical calf stimulation, which is through a device called the Gecko device, improved the Volta score, venous clinical severity score, so that was a clinical improvement and improved quality of life. And in lymphedema treatment, exercise made absolutely no difference. So all of these are attempting to increase venous return and improve blood flow through the system. That's overcoming the blockage in the M25 and trying to encourage the body to make B roads. One of my research fellows did a survey just on a bit of looking at what attitude of patients that had VT would be towards exercise. And we asked a bunch of questions about patients. Mostly people were positive about exercise, and not everybody is. There's some people who get such bad blood clots that they can't do anything, and exercise becomes so painful, it becomes extremely difficult to do. And we were trying to look at whether app-based exercise programs to try and provide some support, because there is a lot of evidence from arterial disease when you get blockages related to smoking and so forth, that supervised exercise programs make a real difference, whether we could introduce some form of supervised exercise. And what we're trying to do, and this is something called plethysmography, which is a way of measuring venous returns. It's an objective way of trying to look at what actually comes back from the leg, and does the leg empty blood when you exercise. And what you get is this graph, which is taken from, you can see these sort of stick figures here, where in the first place you have a patient and you lift their leg up in the air to empty it completely. You then get them to stand up without moving for a few minutes while all the blood returns to the leg. And then you do a sequence of calf raises to activate the calf muscle pump. And what you're looking at is what that pattern looks like. And that pattern can show you whether or not you've got venous disease. So basically what happens is, in people who've got a blood clot, or who've got post-thrombotic syndrome, who've got damage to their veins, the blood takes a lot longer to empty from the leg. And what the consequences of that are is you start to get a buildup of blood that has less oxygen in it, and that leads to things like leg cramping, pain, and discomfort. So off the basis of that, we introduced these simple series of exercises built with our physiotherapy department and based around what we'd recommend to people who've got post-thrombotic syndrome to try and see if it would help. And they are basically built around trying to improve the calf muscle pump. So there's some exercise you do with a chair to do calf raises. There's a soleal stretching exercise and a gastroc stretching exercise against the wall. There's some balancing exercises, and then some leg hopping and lunging exercises. And we've been doing this now for some time with a group of volunteers as part of a clinical study. We don't have the final results yet, but what we have seen is that with that supervised exercise, with what are really simple exercises that can be done at home, not complicated, we've seen quite big improvements in patients' quality of life. I wouldn't say you get back to what people were like before they had the blood clot, but it certainly makes a difference. And then the other options that I kind of talk to patients about, apart from exercise itself, are there's quite a lot of evidence for some group of drugs called MPFFs, which is micropyranide flavonoids. And the common trade name for that drug is a drug called sulodexide. It's not available in the UK. It is widely available in the United States and in Europe. You can get it over the counter in France and Spain, for example. And these drugs are what we call venoactive drugs. In other words, they improve the tone of veins, which is the ability of veins to drive blood back into function. So it's a bit like toning up your body. Generally, if you do some exercises, all your muscles just work better. So if you're fit, so it just helps to make the veins fitter in basic terms. So those have got quite a lot of evidence that they help with leg swelling and cramping. You have to take them all the time, but they're relatively low in side effect profile and pretty benign drugs. The only problem in the UK is you can't get them. Horse chestnut extract, which you can get on Amazon, has got an active ingredient called diosmin, and this again is a venoactive drug. And I've had a few patients who've really found a difference from taking horse chestnut extract in terms of just basic symptoms like leg swelling and discomfort. Then there's a lot of the muscle stimulator devices. There's a device called Revitive, which in both of them has become famous for flogging. Again, there is some evidence to support Revitive for improving circulation. You have to get the top of the range device. The others don't really work. So, that's about £300. So it's quite expensive. And then the final thing that we've seen some evidence for is a thing called the Gecko device, which is a little plaster that you stick on the back of the calf, and it activates the calf muscle pump. And that has got some pretty good data to show that it makes a difference to leg swelling and to improving drainage of blood from the leg. The problem with them is, again, they're quite expensive and you have to keep changing the plaster. So they're useful in a lot, those Gecko devices, for perhaps somebody gets a leg ulcer to try and help the calf muscle pump work better. But what you see from all of this is, the only other thing I haven't mentioned here is stockings, is that these options are pretty rubbish. Everybody hates stockings, and stockings are really difficult to wear. And what I kind of give advice to patients on is we only have data from trials out to 2 years for stockings. And the data is pretty equivocal, is that stockings really are about making leg swelling better. And if you like wearing the stockings and they help you, then wear them. But if you find that the stockings are awful and you hate them, you can't get them on, and you're not getting an improvement in your symptoms, then stop wearing them. And there's certainly some people who are worse in stockings than they are not in stockings. So it's not a hard and fast rule, stockings. It's a pragmatic thing that if they make you feel better, then wear them. And if they're not, then there's not a huge amount of evidence to say there's a right or wrong answer to the question of stockings. One of the other things that is interesting that we found in our research is this concept of cardiopulmonary exercise testing, where you look at how people respond to exercise when they have a blood clot. And we spoke about that before, that a lot of patients I see are short of breath, and they're not short of breath because they've had a pulmonary embolus. They're short of breath because they can't get blood back to their heart when they exercise. And we looked at this in a group of patients that we treated, that we had put stents into, where we looked at how they could exercise before we put a stent in, and then we looked at that again after stenting. And we had this really clever piece of equipment where you could go on an exercise bike and an MRI scanner, and you could scan the patient's hearts before and after exercise and measure how much better they did. And you can see in all the boxes, what we got was a big increase in ability to exercise after reconstructing veins. And this was even in some patients who were really exercising quite well. One chap was already cycling up to 100 miles a week, but his performance on CPEX for that was well below what it should have been, and increased really quite dramatically once he had reconstruction. And these are some other measures of exercise that you can see here. Sorry, these slides are jumping a little bit, which is what your heart rate does pre and post IVC stenting. So the point that Alex was making about obsessing about his heart rate, if you've had a big blood clot, your heart rate actually doesn't respond normally to exercise. So you can see that patients pre and post IVC stenting, their heart rates from resting to exercise was improved, and we saw improvements in other measures of cardiac function. So there's objective evidence that blood clot reduces your ability to exercise. You can improve that a bit with exercise without intervention, and then most of the improvement comes from doing something about big blood clots if we need to. So I'm going to stop sharing there, and then we've got time for more questions, I think.
Thank you, Stephen. Again, really interesting and informative. Thank you so much. There are some questions, and I know others will hopefully be sending some in as well. So a question from one of the audiences: in DVT patients, what's the guidance around moving or resting for the first few days immediately after diagnosis? I think they're meaning.
Yeah, so that's often been an area of controversy. And I think, like a lot of things where doctors get kind of stuck in what was being done 40 years ago. And, 40 years ago, patients with DVT would be put in bed rest, strict bed rest, legs elevated, not allowed to move, all that sort of stuff. Actually, the evidence would favor the sooner you get moving, the better, right? So that's assuming, one, you're on anticoagulation, which is important, but then actually movement is really crucial. So getting going, getting your exercise building up, and trying to do more is better for you than resting and doing nothing. And it actually reduces your chance of PTS if you can get back to exercise quickly. So I think Alex outlined it beautifully in his talk, which is start to do stuff, start to get going, and that's where I think the stockings actually do help in that early phase. A lot of the studies didn't wear stockings early enough. For patients, if they're in bed, they have an intermittent pneumatic compression on, which is that calf squeezing device. I think all of that makes a difference, and the sooner you get on with it, the better. So I think it's really important to get moving.
Thank you. It's like from somebody else, but linked as well really with that. So movement is really important as providing you're anticoagulated and advised, but as soon as possible after diagnosis. How about travel though? And this isn't necessarily long distance, but for extended travel, whether that's car, coach, airplane, whatever, what's the guidance? Somebody's asked, when can you travel after acute VTE diagnosis?
So I'll just hop onto that quickly, but there was a follow-on from the question that just popped up there, Joe, was that does early movement still apply if you're waiting a scan, or physios are usually reluctant? So it doesn't matter where the clot is. It doesn't matter if it's in your IVC or your leg or anything else, getting moving is important. And it doesn't matter if you're waiting for a scan or not. The misconception is that the clot is going to move. Now, most of the time, the PE, or the blood clot to your lung, has happened right early on. It's one of the first events. After a few days, the clot is actually quite sticky and starts to stick to the vein wall. It starts to become part of the vein wall. And then the anticoagulation is designed to stop clot propagating. So the kind of concept is that if you exercise, you're going to give yourself a PE. That's just not correct. So a lot of physios are reluctant because they are scared they're going to dislodge clot and give you a PE. So that's a sort of thing that's stuck in people's heads, and that's not particularly true. So movement, getting active, the central message is start getting moving as soon as you can after a blood clot. It's helpful. In terms of travel, really probably we'd say 2 weeks. There's no hard data that says yes or no, but the highest risk of anything after an event is the first 2 weeks. Once you're established on anticoagulation, you can then fly and travel. It really isn't an issue. There's a difference between short haul, which is defined as anything less than 4 hours, and long haul, which is more than 4 hours in terms of risk of further blood clots. But if you're on anticoagulation and you wear stockings and you keep yourself well hydrated, then you should not be unable to travel. And I would normally say to somebody, just give it 2 weeks, and then start getting back to your normal routines.
Brilliant, thank you. You spoke about stenting, and there's a question here about stenting post-DVT. Obviously, not everybody will need stenting, but what are the key indications when you would consider it?
So I think that stenting has a role in patients who have iliofemoral DVT. That's DVT from the groin up. There isn't really a role for stenting in clot that just involves the thigh or the calf. So that's the main place we'd look to stent. And then generally, I wouldn't either be treating patients really early when they have the initial blood clot, which ideally we want to get to them within 2 weeks for that blood clot. And then we'd use a stent to treat an underlying causative lesion, which is normally the May-Thurner syndrome type of thing. If it's later than that. Generally, I like to see patients wait until about 6 months, because you do see big improvements after blood clot in the first 6 months. And you know, I read a book many years ago, The Art of Medicine is do as much nothing as possible. So if you don't need a stent, don't have a stent. It's about seeing if you recover in that first 6 months. And it's a very frustrating time. And again, Alex did a wonderful job on outlining that. That whole kind of challenge of getting over the psychological aspects, the physical aspects, and getting going. There's a lot of people who are just desperate to be back to normal and have a switch that turns everything off. And it's a really dangerous trap to fall into, to think there is something that is going to do that, because everything carries downsides. So ideally, then I'd wait until 6 months and then consider a stent in somebody who's got really significant symptoms at that stage, quite bad PTS, can't walk, can't exercise, those sort of things. And we start to look at options for stenting.
Brilliant, thank you. Now, I'm not sure which order to do these, but we've got time. So has there been any noticeable reduction in post-thrombotic syndrome since the use of DOACs became established in DVT treatment as compared to during the warfarin era? So,
it's a tricky question, that. So there haven't been substantial direct trials in post-thrombotic syndrome for long enough or large enough to say for sure that it's reduced it. There are some suggestions that there is a benefit. There was one study that showed that rivaroxaban reduced PTS when compared to warfarin. But when you look at the numbers in that study, the PTS rates in the warfarin group was much higher than we've seen in any other study. And the rivaroxaban group was about the same as we've seen from most other studies. So my interpretation of that was that we don't really have enough to show for sure yet. But I would say that compliance is a big reason why anticoagulation works. And I think people find it much easier to take DOACs and warfarin, and you get much more consistent anticoagulation. And there are some aspects of the DOACs that allow clot to break up more effectively. So I think in principle, in theory, I think the DOACs should reduce the rate of PTS, but we haven't had a large enough study to prove that for sure yet.
Yeah, thank you, that's brilliant. And then some of them are physical things. So somebody's asked if thrombosis affects the vein tissue or valve temporarily, or whether this is always a permanent effect.
So it can be temporary, it can be permanent. So if we look at where the clot is and how big the clot is, that really makes a difference. So if you consider clot that's below the knee, just in the calf, that you get a DVT, 90% of that clot will resolve completely. And most patients who have that calf-only DVT will get back to completely normal. If it extends up into the thigh, that number drops to about 70%. And then if it goes above the groin, involving the veins in the pelvis and into the inferior vena cava, then that number ends up being probably much lower, and then you're getting to about 50-50. There are no valves above the groin. So the problem with clot from groin to heart, so iliac veins and IVC, is not about valves, that's about obstruction. So that's blockage. So if you have blockage, you just build up pressure in the veins. The valves are in the thigh, and in that segment, if the clot is there, it can damage the valves, and then you end up with a problem called reflux, and that is and can very often be permanent. So that's where people end up coming to us after 6 or 7 months with post-thrombotic syndrome, is they've got permanent damage to the veins. And what that looks like is the veins get scarred up. So veins are supposed to be a capacitance vessel that gets bigger and smaller depending on how much blood flow happens. Once they become scarred, they become fixed. And if that fixed pipe is now not big enough to cope with demand, so that comes back to the analogy of the M25. If you've taken it from 4 lanes down to 2, and you can't expand the M25, it means you're fine in the middle of the night. But as soon as you try and do any exercise, which is rush hour, there's just not enough capacity, and you start to overwhelm it. And that's really what happens. So that can be permanent.
Thank you. And then again, on a practical point, are the MPFFs or horse chestnut extracts okay to take while on a DOAC or anticoagulation as a whole, whatever they take?
Yeah, so they have a mild anticoagulant property, the MPFFs and the horse chestnut extracts. So, but it's very mild. So I do have patients who take both at the same time to see if the venoactive properties are going to be helpful. you obviously have to be sure of your bleeding risk, and bleeding risk is related predominantly to age. So the older you are, the more careful you have to be with anticoagulants. But they are, on the whole, okay to take with both.
Thank you. And then, really, a question for me. So we are often asked by HCPs about if there's any information. You've shared a lot today, but you also shared a fact sheet, which you have obviously used locally within your own hospital trust. Is there a depository or a network where individuals who might be working in a different trust can access those sort of documents that they can share with patients that they're being asked questions or dealing with?
So with the sheet we had for exercises that we've developed, we're going to hopefully make that more widely available. And then I think what we'd want to do is link in with Thrombosis UK with yourselves and make that available. Any other hospitals who want to reach out to us, we're always happy to share everything we've got. The idea is we're trying to make that into an app that just gives you some guided exercise programs that have been designed by a physio with an interest in this field and tested to make sure that they're safe, that you can build up your exercise gradually afterwards. And that's why they focused on calf muscles and stretching exercise around the calf and building up leg strength, because that's the key to getting things going again. So they're not complex exercises, but we can definitely share them.
Thank you. And then if you were to have a crystal ball, in looking into the future, two questions really. Do you think, obviously we would like more research on this area, so there can be more information, more shared, but do you think there will be opportunity, funds permitting, for more physio opportunities to support individuals after an acute VTE to regain their confidence and their knowledge on how to begin to rebuild exercise?
I mean, I would love to say that I would see a time when that happens. I think the NHS is in such a dire state at the moment that trying to get anybody involved in that is quite difficult when the demands, and there's not enough physios, full stop, and the demands on the service are so enormous. I think that DVT and blood clots continue to get overlooked as a general thing. It's a constant fight to ensure that patients have the right treatments. I mean, you look even at a hospital like ours, where I've got an established service. At the moment, the waiting times for treatment are 65 weeks because everything else gets prioritized all the time. So I think it actually is really about groups like Thrombosis UK and patients and everybody on this making the noise, and you see that working for other areas like breast cancer and so forth. It's that really strong lobbying from patients that start to change the attitude of the government and the health service to what they should provide, and I think that's really important. So I'd hope to see more of this coming from physios. We've got 2 physios now who are going to pick up the do their own PhD work in exercise specifically for DVT patients, because there is nothing. So I hope as we build that evidence base, we can also make people more interested in something that gathers momentum.
Thank you. I'm aware we're short of time, but I think what you've highlighted, and also what Alex highlighted, the effect of being able to do something physical, whether it's a walk or a cycle or a more challenging run or whatever, really does help your mental recovery as well as your physical recovery and future well-being. So it really is important. It's just getting it into place. Thank you very much.
There's a couple more quick questions there.
Do you want to go through those? Yeah.
Yeah. So, John, I think your comment about warfarin being a lost art is probably part of that. I was really surprised at the PTS rates in that study, and I think you're right. If people forget how to take warfarin and stop managing it properly, then it's really much more difficult. But that again speaks to potentially why the DOACs have been as successful as they are. And then in Femia, you've asked a question about taking anticoagulants for long-haul flights. And it's a common thing. We get a lot of patients ask about that. I'm a big fan of taking anticoagulants for long-haul flights, particularly if your blood clot may have happened around a long-haul flight. Because if that's the risk and we can't identify anything else, then doing something to prevent it would be absolutely fine. And how you suggested there, taking a Pixaban before and afterwards is totally right. I often just advise 48 hours before and after the flight because that's the risk time. and the DOACs work very quickly and then stop working very quickly, so you don't necessarily need them for the whole week. But I think it's totally reasonable for you to do that. It is off license. Everything, I mean, it's off license to give DOACs for post varicose vein surgery, thromboprophylaxis, because they've only been tested in orthopedic surgery, and so off license sometimes is a hard thing that we've got to work around. And then there's one comment Uzma has talked about: any role of IVC to prevent travel, including proximal thrombosis. I'm assuming that means IVC filters rather than anything else. Our general view on filters is that filters should be avoided at all costs. They cause more problems than they solve. They've not been shown to prevent death from PE or any of the complications, and we only use filters in exceptional circumstances. So I don't really see if that was the point of the question, a role for filters.
Thank you. Thank you so much, both of you. Lots of questions from the audience, which is brilliant, but also really interesting perspectives and information about the recovery and regaining energy, exercise and well-being after a VTE from both the scientific and medical side and the personal. So thank you both so much. Really grateful to you.
Pleasure.
Thank you.
Thank
Been
you.
a privilege
Bye.
and a pleasure. Thank you.